Hello, everyone, and welcome on today's webinar prepared by Hinovawa Biomedical. My name is Marcin Pacek, and I'm a Senior Director at Hinovawa Biomedical, and I'll be hosting today's webinar. Dr. Jelena Althonainnerova works from 2004-2009 as a resident in clinical pediatrician in the Department of Children and Adolescent Medicine at the Third Faculty of Medicine in Charles University in Czech Republic in Prague. From 2009 to present, she's endocrinologist of the endocrinology outpatient clinic in the Department of Children and Adolescents Medicine at the Third Faculty of Medicine at Charles University in Prague, Czech Republic. Her research interest is focused on genetic aspects of obesity, role of infections in obesity, metabolic syndrome in obese children and adolescents, glucose hemostasis in overweight children, eating attitudes and health risks, and also the roles of ketone in diabetic children. And now we'll give the stage to Dr. Hainerova, and she will present us the webinar entitled Use of Blood Beta-Hydroxybutyrate in Pediatrics. Dr. Althun, now up to you.
Thank you, Marcin, for the introduction. I'm Irina Althun. I'm the pediatrician and pediatric endocrinologist and diabetologist working in the Faculty Hospital Královské Vinohrady in Prague. I also work in the Third Faculty of Medicine, Charles University, and I'm really happy to be able to present the lecture on the use of beta-hydroxybutyrate in pediatrics. I'd like to do the first an overview of the presentation. I'll focus on the ketones in the normal and abnormal conditions. We'll talk about diabetes ketoacidosis, diabetes management during illness, and I'll show you a case of DKA during illness. And the second part of the talk, I'd like to show the use of BHB in the differential diagnosis of hypoglycemia in pediatrics. And we'll show a few additional situations where the blood BHB monitoring may be of use. And I draw some conclusions. So what are ketones? We know we have three. It's acetoacetic acid, it's beta-hydroxybutyric acid, and acetone. So acetoacetic acid or acetoacetate is the first ketone that body produces. It's created from the breakdown of fatty acids and sometimes of amino acids, and it's either used as an energy or it's converted to beta-hydroxybutyric acid or into acetone. It is detected in the urine, and it serves as a proxy measure of beta-hydroxybutyric acid. On the other hand, beta-hydroxybutyric acid is the most prevalent ketone body. It is most energy efficient, and it's produced in the high quantities after sustained carb restriction. It's used as an energy in the muscles, in the heart, brain, and also other tissues. And it's measured with a blood ketone meter. And at last, acetone. So this is spontaneously formed after acetoacetate is produced, and in the body it doesn't have any use, and it can be measured by acetone breath meter. And again, it serves as a proxy measure for BHB level. So where are ketone bodies produced? So they are all the ketones are substances that are produced in the liver during gluconeogenesis when blood glucose is low, either during starvation or periods of fasting. We know that normally liver and the brain prefer glucose as a source of energy. However, when the blood glucose is low, then the liver has to convert either amino acids or lactate or pyruvate or glycerol into glucose for the brain. During the mechanism called gluconeogenesis, and we know the ketone bodies are the byproduct of this mechanism. Muscles, they can switch to fatty acids for energy in order to conserve glucose for brain. And even brain, after 4 days of starving, may switch to ketone bodies. So what happens if there are high ketones detected in the body? We know that high ketones lead to lower pH of the blood, leading to acidosis, and acidosis may impair enzymes in the body, and that can be life-threatening. So I would like to show you some possible use of BHB monitoring in diabetes, and that one of that is diabetes ketoacidosis and then illness management in diabetes. So first of all, I would like to draw your attention to diabetes ketoacidosis, and as a pediatrician I will mostly talk about the type 1 diabetes in children. So DKA can develop at new onset of type 1 diabetes, but also it can develop in already established type 1 diabetes. And that can happen, for example, when children omit insulin, or those with very poor metabolic control or previous episodes of DKA are at risk for another episode of DKA. Or children who are acutely ill, for example, gastroenteritis with vomiting and inability to maintain hydration. Or children with psychiatric disorders, including eating disorders, or children with difficult and unstable family circumstances, and girls around puberty age, binge alcohol consumption, and children with limited access to medical services. So DKA at new onset of type 1 diabetes in children, what do we know? We know that the incidence of DKA of new onset type 1 diabetes varies widely in the world, and it differs from country to country, and we know that it ranges from 15% up until 80%. What we also are aware that younger the children are, the greater the risk they are to develop DKA at new onset of this diagnosis, especially those younger 2 years of age. Unfortunately, ketoacidosis in children is the leading cause of mortality and morbidity associated with diabetes worldwide. And to reduce not only morbidity, but also mortality is to prevent the ketoacidosis, not only those at new onset, but also at those with the established diagnosis. Unfortunately, in the last 20 years, the percentage of children not diagnosed until they are in DKA has not changed. So what are the markers for DKA? We've got both. We've got biochemical markers and clinical markers. What is very typical, and that's a criteria for DKA, is high blood sugar, that's above 11, venous pH below 7.3, low bicarbonate level below 15, and elevated blood ketones that usually above 3 millimoles per liter, or positive urine dipstick. From the clinical markers, we know that the patients with diabetes may suffer many days or even weeks with polyuria, polydipsia, and in the acute presentation, they may be really well dehydrated. They may have tachycardia, tachypnea, and so-called Kussmaul's breathing. There breath has the smell of acetone. They may present with nausea, vomiting, abdominal pain, and also there can be a disturbed level of consciousness. So some of these patients, when they come usually to A&E, they may be like patients with appendicitis or asthma or gastroenteritis. So what is the normal state when their insulin is available? So this is a blood vessel. In the blood vessel, you've got blood glucose that is presented by the white cubes. If you have insulin here as a key and a cell, the insulin is able to open the gate to the cell, and then the blood glucose enters the cell, and that can be used as an energy. In this normal state, you've got normal blood glucose and no ketones available. However, if there is no insulin, and that's the case of type 1 diabetes, what happens? So you've got blood vessel with blood sugar, you have a cell, you don't have any insulin, and it's impossible that the blood sugar enters the cell because of the lack of insulin. So fatty acids in the liver through are metabolized into ketones. And there is a high blood glucose and high ketones. What is the pathophysiology of DKA? I just go fast in this diagram. So you've got absolute insulin deficiency or insufficient insulin or during stress or infection in the diabetic patients. There is a rise of counter-regulatory hormones such as cortisol or growth hormone that leads to increased lipolysis. Free fatty acid level increase in the liver, and ketogenesis is also increased, leading to acidosis, as was mentioned earlier. Also, there is proteolysis and glycogenolysis, which again leads to high blood sugar. And the high blood sugar leads to osmotic diuresis, dehydration, and acidosis. So the glucose depletion on the cellular level leads to the fact that fat are used as the main energy source, and in the body, in the blood, there are increasing levels of ketone bodies, which lead to the nausea, vomiting, acidosis. The loss of body fat, muscle mass, and water leads to weight loss, which is often observed in these patients. So how do we manage DKA? So as I've pointed out, according to the definition, DKA is when you have pH below 7.3, bicarb level below 15, and blood ketones above 3. I just want shortly to also point another situation where you have very high blood glucose, mostly above 35, but you have no significant ketosis or acidosis, and this state is called hyperosmolar hypoglycemic state, and you treat it differently. So in the DKA, it's important to do fluid calculations where you calculate your deficits and maintenance, and the deficit is calculated based on the degree of dehydration, which is calculated based on the severity of DKA as shown in these boxes. You start on insulin IV continuous infusion at usual rates as shown here. And of course, monitoring is very important, and not only by health professionals like doctors, but also nurses. They should do hourly capillary blood sugar and 1 to hourly capillary blood ketones. And the patient should go under medical review based on the status. It's usually 2 to 4 hourly. We also send some labs, USANEs, and so on. The further management is based on the development of the state. So once the blood sugar drops below 14, we consider switching to fluids containing 5% glucose. If the blood sugar drops below 6, then we may switch to 10% glucose. When we reach the situation where we measure BHB level below 1 millimoles per liter, we consider switching to subcutaneous insulin. So what is the illness management in diabetes with the use of BHB monitoring? And you've got two situations. One is with high blood glucose, another is low blood glucose. In both of these situations, your BHB levels may be increased. So let's have a look at the high blood glucose scenario. Blood sugar above 14, you should always be aware, is there any signs of DKA in other words, is there polyuria, nausea, vomiting, dehydration, abdominal pain? And the second thing, you check capillary BHB level. If it's below 0.6, there is no need to change anything, it's normal. If it's between 0.6 to 1.5, you may offer to your patient sugar-free fluids, and even extra insulin dose may be required. If it's above 1.5, again, sugar-free fluids and extra insulin. This table shows the blood ketones level and blood glucose levels, and then it depends what is the level of the sugar and the blood ketones about what is your management. You may increase your insulin dosing, and once you reach your blood sugar above 22, and if ketones are above 1.5, you may even twice your illness insulin dose. And of course, in all scenarios, it's very important to recheck blood sugar and BHB level within 1 to 2 hours. If a patient is vomiting, gastritis, and low blood glucose is the problem, you also check your blood ketone level. And because of you check the starvation ketones. And again, this table shows the management. What do you do based on the level of the blood sugar and of the blood ketones? I'll just show you the scenario where your low blood glucose is below 5 millimoles per liter, but you've got high ketone levels above 1.5. That's a scenario where you don't reduce your insulin dosing. You give usual bolus, but you offer sugar fluids and extra carbs, and you again recheck blood glucose and ketones. However, if vomiting persists, you consider medical review as soon as possible. So just a case of DKA in type 1 diabetic patient with acute gastritis. It was a 10-year-old boy that was diagnosed with type 1 diabetes since he was 4.5 years. He was on multi-daily insulin injection with continuous glucose monitoring. And he was admitted to A&E for vomiting at night, no fever, no diarrhea. He had acousmal breathing and he was dehydrated on presentation. And his blood sugar with the PCOT was high in the lab. It came back as almost 39 millimoles per liter. And he fulfilled the criteria of diabetes ketoacidosis with pH below or around 7, bicarb 6.2, and BHB from the PCOT was 5.5 millimoles per liter. So this is a table showing the development of the blood sugar measured by PCOT device and BHB level, again measured by PCOT devices. So at admission, the blood sugar was very high, BHB was 5.5, and you start with your management fluid rehydration, usually with saline. You start IV continuous insulin infusion and nothing by mouth. And here you see by 5 hours after admission, the BHB level starts to drop. You continue your fluids. 8 hours after admission, the blood sugar is around 14. At this time, we switched to 5% glucose. We also added at some point potassium. We continues with the insulin infusion. And 11 hours after admission, the BHB level drops to 0.9. At this point, if the patient would eat normally, we would have switched to subcutaneous insulin, but because of not feeling well, not eating, we have continued. And you see later on at 23 hours after admission, his BHB level stabilized. He eats and drinks, fluids are off, and we could switch to subcutaneous insulin. At the second part of the presentation, I want to focus on the use of BHB in the differential diagnosis of hypoglycemia in pediatric patients. So what is hypoglycemia or low blood sugar? It's a plasma glucose concentration that is low enough that can impair brain function and cause symptoms. From the definition, you know where infants below 6 months is blood sugar below 2.6. Above 6 months of age is blood sugar below 3. However, we have to be very cautious if there are no blood ketones detected, there should be higher limit of the blood sugar, and we usually set it to 3.5. So what are the symptoms of hypoglycemia in infants, neonates? It's usually poor feeding, irritability, hypothermia, pale skin color, jitteriness, tremor, or even seizures, or the patient can have a high-pitched cry, grunting, or even apnea. So these are the situations where you consider checking blood sugar as soon as possible. In the neonates, just who is at risk? So there are some maternal factors. Mothers that have diabetes, not under good metabolic control, they are at risk to have an offspring with risk of low blood sugar. Also those mothers being on, for example, beta blockers. From the neonatal point of view, it's all those that are born preterm or small or large for gestational age, or those with perinatal hypoxia, hypothermia, sepsis, or respiratory distress or syndromes. So let's show you a case of a newborn. This is a 33-weeker that was born with this birth weight, which was rather high for his gestational age. He was born with a cesarean section for breech position, and at 2 hours, he was found to have tachypnea and lethargy. So at this point, you check blood glucose. And this came back as 1.6 millimoles, which is low. So the second thing you do, you check ketones. Of course, you have an option to check urine for acetoacetate, but it's rather challenging to wait for urine sample in children and especially neonates. So you may check the capillary BHB level via the POCT device, and you have the result immediately. And this BHB level at the time of the low blood sugar was really low. You may even send a blood gas. At this time, you have a kid with low blood sugar, low ketones. Before treating, you need to get a critical sample at the time of low blood sugar in order to get a differential diagnosis. You send some blood to the lab as glucose, insulin, C-peptide, cortisol, growth hormone, free fatty acids, and other metabolic substances. You check the urine also for metabolic substances, because these results helps you to differentiate and find out the diagnosis and the reason, the cause for low blood sugar. So you have low blood sugar, you check the BHB. If you find the BHB level is increased, so-called ketotic hypoglycemia, you may check lactate. If the lactate is high, there might be the cause of some metabolic disorders, such as disorders of gluconeogenesis or others. If there is a normal lactate, it may be normal or so-called ketotic hypoglycemia, a condition that is very much found in kids around age 3 to 5, but it can also be in those with growth hormone deficit or cortisol deficit or other metabolic disorders. On the other hand, if the BHB level is low, so no non-ketotic hypoglycemia, you may check serum insulin. If it's detectable at the time of low blood sugar, it means there is a hyperinsulinism, which can be either transient or permanent, or it's a case of insulinoma, it's rather later in life, or factitious, meaning the kid has exogenous intake of insulin. By checking C-peptide, that can help you a lot. If the serum insulin is suppressed, you may have a defect in fatty acid oxidation. With that, the free fatty acids are increased. So what were the results of the critical sample of our case? So lab blood glucose was also low. Lactate, ammonia, cortisol, growth hormone were all normal. However, C-peptide and insulin at the time of low blood sugar were detectable, and free fatty acids and BHB levels were low. This was a case of congenital hyperinsulinism, and this is very important, where the BHB level, where you accurately have the level right away, you may have the diagnosis pretty early and start treatment early. What are other situations where monitoring of BHB level may help? That may be in the scenario of fasting, for example, in those with eating disorders such as anorexia nervosa, or in keto diet where there is a high fat and low carbohydrate content, or keto diet is sometimes used in pharmacoresistant patients with epilepsy or those with autism spectrum disorder. What are the take-home messages? So, availability of accurate and instant BHB level is really important for various conditions in pediatrics. And it should be monitoring of BHB level should be an integrated part of DKA management, but not only DKA management, but we know that blood BHB level and the monitoring during illness, not only in the hospital settings, but also at home in patients with type 1 diabetes is very useful. And at last, blood BHB level is very helpful in differential diagnosis of low blood sugar in children from newborn to adulthood. Thank you for your attention, and I'm happy to turn it back to Marcin.
Thank you very much, Dr. Hinovawa, for this really interesting and in-depth insight into ketone measurements in diabetes in children. Now, without further ado, I would like to switch for another short presentation entitled Ketone Measurements, What, Why, and When, which will be focused on some of the additional information regarding ketones, not only in pediatrics. Now, I would like to focus your attention on another short presentation, this time entitled Ketone Measurements, What, Why, and When. Now, let's focus on blood ketone levels and the type of ketones we can encounter when we want to measure ketones. So, as we already heard, beta-hydroxybutyrate accounts for about 80% of all ketones. Now, the rest of the ketones, acetoacetate and acetone, account for up to 20% of all the rest of the ketones body we can find. Now, how we can measure ketones? We can measure ketones in urine, we can measure them in serum and plasma, and we can also measure them in the whole blood. Now, if you look on ketone measurements in urine, this can be done in a point-of-care format or in laboratory. The result is unfortunately always semi-quantitative. You can use dipsticks or test tablets, and the test only measures acetoacetate. And as we remember, acetoacetate accounts for less than 20% of total ketone bodies in your blood, in your body. If we measure ketones in serum and plasma, this can be done in the laboratory or in the point-of-care format. It can be quantitative or semi-quantitative, depends on the method we use. And if we measure ketones in serum or plasma, then we are measuring beta-hydroxybutyrate. And finally, we can measure also ketones in the whole blood. This is done by POs, point of care or self-test methods. This is always quantitative method, and we always measure beta-hydroxybutyrate, which, as we remember, accounts for 80% of all ketones. Now, why measuring of ketones is important, and not only in diabetes in the children department, as Dr. Hinovawa told us, but also in general. So here we have a few important points from different recent publications. Why early diagnosis and treatment of patients with DKA is important to avoid significant morbidity and mortality. And now from Sheikh and al. In 2008, the authors concluded that beta-hydroxybutyrate allows a rapid diagnostic of DKA or a redirection of diagnosis among acidotic patients presenting at ED. A year earlier, different authors stated that blood ketones are a useful tool that allows clinicians to immediately distinguish between simple hyperglycemia and potentially life-threatening ketotic states. And in 2006, another group of investigators published that the point-of-care test for beta-hydroxybutyrate is more useful than glucose alone for the diagnosis of DKA and offers immediate diagnosis of patients at triage. Now, from another group of authors, if we focus on ICU and pediatric ICU, the authors stated that DKA patients monitored by blood beta-hydroxybutyrate left the ICU 6.5 hours earlier than patients monitored with urine ketones. And now that accounts for almost 30% of cost saving for lab tests and 70% reduction in clinical assessment. That was a publication in 2007. Before that, Vanelli and all published that DKA patients monitored by blood ketone reach an endpoint for intravenous therapy after 17 hours versus 28 hours for patients monitored by urine ketone testing. So clearly in the ICU for ketotic states, beta-hydroxybutyrate in the whole blood is significantly superior than the urine testing. Now, knowing that we can measure beta-hydroxybutyrate directly in blood, we have to remember that there is a chance for interference in measurements in any point-of-care method. So here is a paper from Ceriotti done in 2015, when the authors compared different measurements from different ketometers. And as we focus on the graph on your left, you have your ketone concentration on the y-axis, and you have your hematocrit concentration in the x-axis. As you know, and as you remember, hematocrit is pretty often an interfering agent, both for ketone or glucose, for example. And in the ICU specifically, you might find patients with a very different and out of normal range of hematocrit due to their treatment. So if you focus on the graphs, you will see that we have 1 meter here particularly, which you can find in the legend. Here you can see it as a red graph. that has very significant interference with hematocrit as compared to stat strip ketones and the central lab reference method. Now, as you look closely on the graph, you will see that there is inverse correlation between the concentration and the bias. So the higher the concentration of hematocrit, you will see the higher ketone, the lower ketone measurements and the higher bias in the measurements. Okay. Now, in a similar way, you will find this also in this poster presented in 33rd AACC International Symposium on the Point of Care Testing in 2010. And here the authors again took central lab measurements of ketone, stat strip, and another meter, which you can find here in the legend. And they show us that there is a very significant, similar as before, hematocrit interference, but also ascorbate interference. And as we know, high concentration intravenous of vitamin C can cause a significant interference for both glucose and ketone measurements, as shown in this case as well. Now, I would like to just very briefly focus on the recent publication and case study about SGLT2 inhibitors. SGLT2 inhibitors, they do inhibit glucose reabsorption from the proximal tubule in the kidney by inhibiting the sodium glucose cotransporter 2, which is responsible for almost 90% of the glucose reabsorption in the kidney, thereby lowering blood glucose level. Now, they do improve HbA1c with weight loss and the low risk of hypoglycemia, and they became very popular in the past few years. SGLT2 inhibitors such as dapagliflozin decrease the risk of worsening heart failure or mortality from cardiovascular events, even in the absence of diabetes, which has been shown in the recent clinical trials, and therefore SGLT2 inhibitors are now widely prescribed not only for the diabetic patients. It has been also shown that the enhancement in circulating ketones has been suggested to mediate the SGLT2-induced cardioprotection. So there is another group of clinical studies where the authors show that increased level of ketones in your bloodstream can induce cardioprotection, and this can in fact be induced by SGLT2 treatment. Now, if we look closer, unfortunately, the increase in ketones for people taking SGLT2 inhibitors can be very significant, as shown here in the case report for 32-year-old Japanese woman that has diabetes with Prader-Willi syndrome, and she was on SGLT2 inhibitors. And she was presented in the ICU with a DKA case. Now, increased risk of developing diabetes ketoacidosis with the use of SGLT2 in patients with type 1 and type 2 has been shown and has been studied, and it is studied right now because, as I said before, SGLT2 inhibitors are now very popular and prescribed widely, not only for diabetic patients. It has been also suggested that the risk of SGLT2 inhibited induced diabetic ketoacidosis can be triggered by other factors such as decreased insulin dose, decreased food and fluid intake, intercurrent disease, and the history of alcohol intake. The problem is so visible and so important that a few years ago, FDA actually issues a warning regarding the use of SGLT2 inhibitors. And as we can see here, FDA is warning that the type 2 diabetes medicines that belong to SGLT2 inhibitors may lead to ketoacidosis, which is a serious condition. Later on, we can read that FDA also advised in those cases to monitor ketones and glucose in those patients to avoid DKA cases and control the patient's progression. Now there's at the very end one interesting study that I would like to show you. This one is focusing on the link between COVID-19 DKA in the diabetic patients. Now this is a study published just 2 years ago, a retrospective observational study done in New York Medical College patients with 6 COVID patients that were in the hospital with DKA. As we can see on the table here, all the patients had a very high HbA1c, on the average 12.5. They have very low pH, on the average 7.03. They have very high beta-hydroxybutyrate, as you can see here in the table. It was above 4.5. And as you can see at the end of the table, unfortunately, a majority of the patients died. The authors concluded that diabetes patients do have a significantly increased risk of DKA when they got COVID-19 infection as well. With this type of patients, there is a high mortality rate associated, and especially when they are under ventilation. They are priority for tight glycemic control, and the authors concluded that more study are needed, and there are several more undergoing, to my knowledge. Going slowly to the end of the presentation, this is our summary for today, and we think that early diagnosis and treatment of DKA is important in managing DKA and reducing morbidity and mortality. It is estimated that roughly half of the hospital admission of DKA could be prevented with improved outpatient treatment and self-care for ketone monitoring. Blood measurements of beta-hydroxybutyrate enable faster DKA detection and improve patient management, and monitoring is superior to urine testing, as we shown before. Several guidelines recommend the use of blood ketone testing for DKA. The guidelines are not unified, but you can find different guidelines in Europe, in the States, and in Australia. And diabetes patients do have increased risk when they have ongoing COVID-19 infection, and they are prone to suffer DKA on occasions. And also the management of diabetic COVID-19 in critically ill patients should therefore include the tight glycemic control and diagnosis and immediate treatment of DKA. Thank you very much for your attention. This ends my part of the presentation for today. And now let's move to the questions we receive for Dr. Irena Hajnerova. So the first question, Dr. Irena, is, in your opinion, what are the biggest differences between the blood and urine ketone testing? Which would you recommend and why?
Oh, thank you for the question. So I would think there are 2 aspects. First of all is the availability, and it's the availability of the sample and of the result. If we talk about the sample, so we know if we need a urine, sometimes it is very tricky to get a urine sample. You've heard that in DKA, the patients come very dehydrated. They are very much, in many times, they are anuric. That's the one scenario. Or you have a newborn or a little infant where you need a urine bag, then it leaks. So that's it may be very tricky to get the urine sample. With the BHB, so with the blood, it's available right away and you get the results right away. And the second part is the accuracy. With the urine only detects the acetoacetate. So it's only a proxy measurement of the most prevalent ketone body, the BHB. On the other hand, if you measure the blood BHB level, you have the BHB level, you have the accurate ketone bodies at the actual state. So I would honestly go for the blood BHB measurement, and that should be done within other protocols or guidelines.
Well, I completely agree with your comment, Dr. Altun. I sometimes working in a different hospitals, I get the feeling that a urine testing for ketones in this particular case is more of a historical approach to ketone testing, and sometimes people do have this method but not really using it anymore because of those limitations you mentioned. But it sometimes is difficult to apply the change and move to whole blood beta-hydroxybutyric testing, which I think is the right way to do, as you just mentioned. Okay, let's move to another question we have. Since it seems important to include rapid ketone testing in the standard hospital protocols, why this method, in your opinion, is still not very popular?
Thank you for the question. I would not think it's a matter of popularity. I guess it's a matter of knowledge, training the staff, training the nurses, at the end training the patients. I train my patients how to do ketone measurements during the illness that they've got. So it's more, and of course about availability of the ketone meters. So it's not about popularity, it's about evidence and trying to apply the evidence on our daily work in the hospital, in the education where we deal with our nurses, with our staff, but also with our patients.
Well, I guess it's not really a popularity contest, but it's more of a what method is available and which tool is really required and gives a good answer. I completely agree with you here. And the very last question we have, because the time is running out, I know that in pediatric practice, you probably don't see many cases, but do you see in any ways in your practice increase in DKA and ketonemia due to wider prescription of SGLT2 inhibitors?
Oh, thank you for the question. So as a pediatrician, I must admit, I don't have patients being on SGLT2 inhibitors. However, from my adult colleagues, as this drug are they are the options for adults with type 2 diabetes, and we know that they can present with so-called atypical DKA. In other words, they may have even normal or only mildly elevated blood sugar, but already being in ketosis. So in the apparently based on the talks with my adult colleagues and based on the literature, and there are a lot of papers published on this matter, patients should be monitored. The ketone bodies should be monitored in these patients before surgery or in the hospital as well. And we know that these inhibitors are not approved for type 1 diabetes. But I have very limited experience, but it is widely known that they are at risk of DKA development. So obviously, ketone measurement should be in place for these patients.
Okay, thank you very much. Thank you for your presentation. Thanks, Dr. Irena, for being here with us. For all of you, thank you very much for your time and attention. If you would like to listen to this webinar again, you can find it on our website at Nova Biomedical. You can find also many different webinars dedicated to different topics. They're free of charge. You can just register and listen to the wealth of knowledge we've accumulated over the years. Thank you very much for your attention, and thank you again, Dr. Irena, for being here with us. Thank you and bye.